behalf of the director of the Ramón Areces Foundation, Mr. Raimundo Pérez Hernández, let me give you a warm welcome to this foundation and to this conference. Let me introduce myself. My name is Daniel Santín. I'm professor of economics at the Complutense University of Madrid, and I'm also in charge of coordinating the activities that are organized or sponsored by the foundation. Today's conference is entitled Investing in Children to Address the Youth Mental Health Crisis, and will be given by Janet Currie, who is the Henry Putnam Professor and the co-director of Princeton Center for Health and Well-being. In addition, Erdal Tekin, who is the Fotis Family Distinguished Professor in the School of Public Affairs at American University, will introduce Professor Currie and moderate questions from the audience. So thank you very much to both of you for having accepted to be here today with us.
Good evening. My name is Erdal Tekin, and I am a professor in the School of Public Affairs at American University. And I am also the organizer of the annual workshop on the economics of risky behavior, which was launched in 2009. And we take it to a different location in the world every year, and we are happy to be in Madrid this year. It's my great pleasure to welcome you to the keynote event of the 14th workshop on the economics of risky behavior. We are honored to have such a distinguished speaker with us this evening. Janet Currie is a professor of economics at Yale University. She had been at Princeton. She is transitioning to Yale University. I guess it is fair to call her bilingual at this moment. She is also the co-director of the program on families and children at National Bureau of Economic Research. She is widely recognized as a pioneer in the economic analysis of child development, and her work has profoundly shaped how scientists understand the early life origins of health and human capital. Her research spans a wide range of critical topics, including socioeconomic disparities in health, environmental threats to well-being, child mental health, and the long-term consequences of early childhood health conditions. She has presented her work at leading universities around the world and influential venues such as the White House and the European Investment Bank. Professor Currie holds honorary degrees from the University of Lyon, the University of Zurich, and the University of Lugano. She's a member of the US National Academy of Sciences, the National Academy of Medicine, the American Academy of Arts and Sciences, and the British Academy. She served as president of the American Economic Association in 2024 and is a fellow of the Econometric Society, the Society of Labor Economists, and the American Academy of Political and Social Science. Among many honors, she was named a Nomis Distinguished Scientist in 2019, received the Klaus Jacobs Prize in 2023, and was recognized as a Clarivate Citation Laureate in 2024. In 2015, the World Economic Forum named Professor Currie as one of the top 10 women in economics. She has also contributed significantly to the profession through editorial roles, including as editor of the Journal of Economic Literature and as a member of the board of reviewing editors at Science, among others. We are deeply fortunate to have her with us this evening. Before we begin, I would like to thank our generous hosts, Ramón Areces Foundation, for their support and for providing us with this beautiful venue. I'm also grateful to Eugene Azuchelli for his partnership and collaboration in organizing this year's workshop. Finally, but importantly, I want to thank the School of Public Affairs at American University in Washington, D.C., the main sponsor of this workshop, for its continued commitment to supporting policy-relevant research and making events like this possible. So please join me in welcoming Professor Janet Currie.
So, hola. Thank you very much for coming out on this rainy day to hear about this topic. I'm going to be talking about investing in children to address the youth mental health crisis. This crisis has been described as the defining public health crisis of our time by the former Surgeon General of the United States. And I think that's an extraordinary statement given the public health crisis that we've just been through, that he would think that this was actually potentially more important. One reason why it's very important is because it affects so many people. The estimates from UNICEF are that about 13% of children worldwide have some kind of mental health condition that impairs their functioning. So that's a very high rate compared to most physical health problems. Now, this problem of a youth mental health crisis is widely shared. This rate of about 13% seems to be true in many different countries. But one thing that's very different across countries is the youth suicide rate. So these two pictures show that the US is a real outlier, both in terms of the level, but also in terms of the trend. In the United States, the trend in youth suicides has been increasing over time, whereas in the European Union, it's actually been falling. And if we look in more detail, for example, at Spain, what you see on the top here is the US line, and on the bottom is the Spanish line. So Spain actually has one of the lowest youth suicide rates in Europe. So I just want you to keep in mind that there's these huge disparities. And so when you're thinking about causes, it'd have to be causes that are different in the United States than in other places. Okay, so I'm going to talk about three different things. The first thing is just about the cost of the mental health crisis. You may be wondering, why would an economist even care about this? And one reason is because it's so costly, as I'll show you. And then I want to talk about what I'm going to characterize as two myths about the crisis. I think it's important to address these because I think they distract us from thinking about things which could actually be helpful. So the first myth is that child mental health problems were soaring prior to the pandemic, so even prior to the pandemic, and that this is just an unprecedented situation. And I'm going to argue that I don't think that that's true. The second thing is that differences in mental health are the thing that are driving the suicide rates. Right? And I already showed you that the differences in mental health are not that great across countries, but the differences in suicide are very great. So that's one piece of evidence which suggests that the two things are not as closely related as some people may think. And then the third part of the talk is going to be about investments that improve youth mental health and prevent suicides. So there's going to be a more hopeful side to this. So talking about the cost, in the US, the cost of providing services to children was $31 billion in 2021, and that's about half of the cost of providing health care to children. And again, the overwhelming reason for that is just because there's so many children who are affected. In addition to these direct costs of providing medical care, there's a lot of costs to families. And one way to see that is in terms of lost parental work time. So parents of children with mental health problems often lose 4 days or more of work annually. Now, in addition to these short-run costs, there are longer-run costs of youth mental health conditions. One cost is that a lot of adult mental health conditions are believed to start in childhood, so as many as half of them. So the children who have mental health problems unaddressed may end up being adults who have mental health problems. And child mental health problems are more predictive than common physical health problems of poorer long-range outcomes. So just as an illustration, this figure is showing some data from a study using Canadian children where we compared children who had mental health conditions to their own siblings who didn't. So along the bottom axis, there's a measure of mental health conditions where a bigger number means that you have worse mental health. And along the vertical axis is just saying, were they still in school some years later? And so what the downward sloping lines are showing is that the children who had worse mental health are less likely to be in school at some future point than their own siblings. There's 4 different lines here which correspond to slightly different mental health measures, but the tendency is the same. So that's thinking about schooling. If we think about social assistance or being on welfare, you see the reverse pattern where, again, this is comparing children with mental health conditions to their own siblings at different ages. And what this is showing is that having a mental health condition is more predictive of ending up on social assistance after age 18 than 2 common physical health problems. One is having an injury, and another one is having asthma, which have relatively little effect on that outcome. Looking at data from other countries, you can see this is from the United Kingdom's labor force survey, looking at the percentage of days lost. Mental health is the leading cause of working days lost. It's much bigger than the next leading cause, which is musculoskeletal conditions like lower back pain. And then that in turn is much bigger than everything else put together. So it's really important in terms of days lost. Looking back again at US data, this is data on disability, showing that mental health is a really important cause of disability, which is one reason why people are not in the labor force at all to begin with. And then some additional costs of mental illness can be seen by looking at things like homelessness, where surveys from a number of countries suggest that as many as 2/3 of people who are homeless have some sort of mental health condition. Now, whether that's a cause or an effect isn't totally clear, but it's definitely related. And in the US, 44% of people in jail and 37% of people in prison have some sort of mental health condition. So that in the US, actually, prisons are the leading provider of mental health services just because they house so many of the people with mental health problems. So in summary, I hope that these sort of brief overview of statistics has convinced you that the child mental health crisis is imposing significant economic costs as well as costs in terms of individual pain and suffering. So turning to these 2 myths, the first myth is that the child mental health problems were soaring prior to the pandemic and had reached unprecedented levels. And the reason why I think this is important to determine is basically because everyone believes that child mental health problems have gotten a lot worse and that it's because of social media. Right? And they think that because of a coincidence in the timing, that we've all become much more aware of child mental health problems in the last 10 years, and we know that social media has really taken off over the past 10 years. So people sort of look at that and think that they must be related. Now, this report, which was from 1970, is called Crisis in Child Mental Health. This is a report that was made to the US Congress, which found that 10 to 12% of US children had major psychological problems. And then they made a whole bunch of recommendations, which were widely ignored. And so, 50 years later, we're still having a child mental health crisis. But periodically, the issue resurfaces. So this is a report that came out in 1970. We see there's another report that came out in 2000. This was the Surgeon General convening people to talk about the youth mental health crisis. They came up with an estimate of about 11% of children with serious mental health problems. So you can see that there's been a fairly consistent estimate of the number of children with serious mental health problems over decades. So it's really not a new problem at all, which is not to say that it's not a crisis. It is a crisis, but it's just not a new crisis. Now, why have we become so much more aware of child mental health, and in particular certain diagnoses, like things like depression and anxiety, which everybody is talking about now and nobody used to talk about? I could go on a long time about this, but I'll try and cut it short. There are two things. One is changes in definitions and the way that we measure different kinds of mental illness. And the third thing are changes within the medical care system, which create incentives both for patients to come forward and get diagnosed and treated, and for providers to provide those diagnoses to people. So I'm going to give some examples of both of those things. Now, in terms of changes in diagnosis and measurement, the thing that's used to diagnose mental health is called the Diagnostic and Statistical Manual of Mental Disorders, or DSM. And in 2013, it was completely revised and a new manual came out. It changed the way that we define and measure most mental health disorders. So some of the important changes were that some additional conditions were added to the definition of major depression. So there used to be a separate thing, which was kind of low-level persistent depression, and that was folded in. Another change, which was kind of controversial, which was to fold in bereavement. If somebody is depressed because somebody died, that's now qualifies you for a diagnosis. And there were also big changes in the definition of anxiety. So one important thing was that post-traumatic stress syndrome, or PTSD, used to be a separate diagnosis, and now it's been folded into anxiety. Okay, so there's some mechanical changes in definition that would cause you to have more people. Another thing that's like that is the way that autism is treated. There used to be 4 separate diagnoses. These were all merged together. And we had a lot of publicity after that saying, oh, look, there's a huge increase in the number of cases of autism. Well, it's because you took one thing and added 3 more things to it. And so you got a lot more people. And then ADHD diagnosis was changed to change the age threshold. So in the old version, you had to have symptoms before age 7. Now you have to have symptoms before age 12. So there's a whole bunch of people where symptoms might have been first noticed, say when they were 8 or 9, who are now eligible to get a diagnosis of ADHD, where they weren't eligible before. Okay, so there's a lot of changes going on, which coincide with these big jumps in the number of people getting these diagnoses. Thinking about incentives, on the patient side, what's the benefit of getting a mental health diagnosis? Well, the benefit is that you could get treated, or perhaps you could get special accommodation in school, perhaps you could get disability benefits. On the cost side, from the patient's point of view, the big cost is that there's a lot of stigma associated with having a mental health diagnosis. But that cost, that stigma, has been declining over time. So surveys show that people are much more likely now to believe that depression might have a biological basis and that it doesn't represent some sort of moral failing of people. And they're also more likely to say that they would try and help somebody who had depression, not that they would just avoid them. Okay? So these kind of factors make it more likely that people will come forward to say that they have mental health problems and try and get treatment. There's also in the United States expansions of insurance coverage that have made it more affordable, which would also cause people to come forward. On the doctor side, there are a lot of changes in the way that people get compensated for treating mental health. So I'm just going to show you one example, which is from a change in the way that doctors in the public health insurance program for children in a US state, South Carolina, were treated. Okay, so it used to be the case that doctors could bill for each service, and then they changed it to what's called a capitated payment system, where you get one payment, and that's supposed to cover all of the cost of care for somebody. Now, that creates an incentive for doctors to provide less care, because the amount of care doesn't affect the payment that they get. And so to counteract that, these contracts built in a bonus if you were treating a child who had a chronic condition. Okay, so the doctors now had an incentive to diagnose people with chronic conditions because they got a higher capitated payment. Okay, so what happened was we could follow the same child with the same insurance over time and say, okay, what happens to the probability that that child has a diagnosis when the doctor is getting more money if they have a diagnosis? Okay, and what we see is there's an increase in diagnoses of mental health conditions, so more kids getting diagnosed with ADHD, more kids getting diagnosed with depression, but there's also increases in things like diagnosis for asthma, finding infections, autoimmune disorders. So it's kind of across the board that you provide this incentive to make diagnoses and you get more diagnoses. Okay. Another example that I'm going to show you is using data from emergency department visits. And so for this, what I'm using is data from a nationwide sample of emergency department visits in the United States. The reason why emergency departments are particularly interesting to look at is because patients with mental health diagnoses are usually advised that if they have a crisis, they should go to the emergency department. So you see people showing up there when they're in crisis. Now, looking at these visits, if you look at the blue line, this is showing all of the emergency department visits that have a mental health diagnosis over time for children 10 to 19 years old. So you can see that that goes up until about 2018, and then it starts to go down up until the pandemic. But I think what's interesting is if I break up all of the visits into just two groups, one group being kids that had any mood or anxiety disorder, and the other group being kids that had any other diagnosis. What you see is this huge increase in the number of kids with mood and anxiety disorders, and an actual decrease in the number of kids being diagnosed with other conditions. Okay, so what that's suggesting is that there's some substitution here, that kids who would have been diagnosed with something else are getting diagnosed with anxiety and depression. And now, some reasons why that could be happening right in 2011, because you can see these things all track very closely until 2011, and then they really diverge. Okay, so what happened around that time? Well, there was a recommendation made that all girls should be screened for anxiety and depression. So that was in 2011, and the Affordable Care Act in the United States said that doctors should be compensated for providing that screening. Okay, so all of a sudden, you can think about many more girls being screened for depression. And then there was also a change in the way that doctors were being reimbursed, particularly for finding suicidal ideation. So essentially, you can put many diagnoses on a case when somebody comes into the emergency department. You can have a primary diagnosis, but many other diagnoses. And if it's a more complicated case, then you get reimbursed more. Okay, so lots of hospitals were providing training programs for clinicians to make sure that they code all of the relevant diagnoses, because that affects the payment that the hospital will get. Okay, so in this figure, what I'm showing is two lines here. So this is the change in 2011 when girls started to get screened. And you can see that the lines are pretty parallel up till 2011. And then we see more girls getting this diagnosis of suicidal ideation, which is one of the things they would ask about when they're doing a depression screening. Okay? And then the second line that I've put here is this change in the way that doctors were being compensated for putting suicidal ideation on the record. And then you see when that happens for both males and females, you have this big increase in diagnoses of suicidal ideation. Okay? So I would argue that it's basically impossible that between in one year and another, 2016 and 2017, you would have a 40% increase in suicidal ideation. So this is showing the importance of these reporting changes. Okay, now, I took a look at some Spanish data. This is from a paper using all the primary care visits in Catalonia for 10 to 24-year-olds. And what I thought was interesting is you see some sort of similar patterns. So looking at depression, for instance, this is pretty flat up until 2012. Then we have a big increase between 2012 and 2014, and then it's flat again. Sorry, there's this should say female and male. I don't know why that little box is there. And then you see it go up during the pandemic. Okay? Anxiety shows a similar pattern. And then, importantly, things don't only go up, right? They also go down. So you see fewer people being diagnosed with eating disorders and fewer people being diagnosed with ADHD. Okay, so I would argue that these patterns suggest there might be something similar going on here with changes in reporting, changes in diagnosis, affecting some of the measured increase in the rates. Also, this article that I'm citing is very interesting because it has some breakdowns by things like smaller age groups. And you see that this increase in depression diagnosis is the largest for 10 to 14-year-olds. It's very distinct. You also see a reduction in ADHD diagnoses in the top income quintile, particularly. So that suggests it's not something about access to care. It's probably something really about how this is being diagnosed. And the fact that some things are going up and some things are going down suggests, again, that there's some possibility of substitution between different diagnoses. Okay, so it seems like the claims data might be subject to some problems if the incentives for doctors really matter and there's changes in screening and so on. So what about using survey data to try and track how mental health is changing over time? I'm going to show you some data which is from something called the US Youth Risk Behavioral Surveillance Survey. And the great thing about this survey is that they've asked the same questions in the same way since 1999 to high schoolers. So you can see how the answers change over a long period of time. So the questions that I'm going to focus on are, first, during the past 12 months, did you ever feel so sad or hopeless almost every day for 2 weeks or more in a row that you stopped doing some of your usual activities? So this is actually quite similar to depression diagnosis in that it emphasizes whether the mental health condition is interfering with your usual activities. Then, during the past 12 months, did you ever seriously consider attempting suicide? And during the past 12 months, how many times did you actually attempt suicide? So this is a completely anonymous survey. Now, looking at these rates for boys in blue and girls in pink, the solid lines are showing the fraction who say that they felt hopeless for 2 or more weeks. And I think you do see an increase at the end of the period, especially for girls. But I think one of the things that's really shocking is how high the rates are to begin with. So even back in 1999, you had 25% or 20% of boys and 35% of girls saying that they felt sad or hopeless for significant periods of time. When you ask about considering suicide, that actually has gone down a lot since the early 90s. And if you look at the numbers for attempted suicide, they are pretty flat, although I think it's still pretty shocking how high they are. So 10% of girls and 5% of boys saying that they've attempted suicide. Okay, so the point I was trying to make is that this youth mental health crisis is not new, it's old, it's been around for a long time. And so now I'm going to turn to the second issue, which is whether these differences in mental health are the main driver of differences in youth suicides across different groups, across areas, and over time. And the reason why I think it's important to think about this is that if these trends don't actually move together, but there are other things that move suicide besides mental health, then maybe those are the things that we should be focusing on. Okay, so looking at how ED visits for suicidal ideation, for self-harm, track with suicides. Here the orange line is the US suicide rate. The green line is showing people who arrived at the emergency department because of self-harm or suicide attempts. And the red line is people who are being diagnosed with suicidal ideation. So they all join because I've made 2006 equal to 1, so you can focus on the trends. Okay, so what you see is that ED visits for self-harm or suicide attempts maybe are a reasonable thing to look at when you're trying to predict suicides because they follow the same trend. But the suicidal ideation numbers are just going way up much faster than actual suicides. So looking at suicidal ideation probably isn't a very good predictor of suicides. Looking at those numbers from the Youth Risk Behavioral Surveillance Survey about hopelessness and suicide attempts and comparing those to the total suicide rate, you can see they don't really track very well. So we see that the suicide rate is basically flat up until 2011, and then it goes way up, and then it goes down after 2017 for this age group, 10 to 19-year-olds. The sad or hopeless thing is kind of flat up until 2018 and then goes up. So the number of people saying that they're sad or hopeless is going up at the same time that the suicide rate is going down, according to these data. And you can see that the attempts, again, is kind of noisy and also is going up at the same time that the suicides is going down. Right? So arguably, none of these measures of mental health are really capturing the time trend in what's going on with the suicides. Another thing which suggests that it's not just mental health that's causing differences in suicides is looking at the geographical distribution. So this is a very shocking thing, I think, in that if you look at the Northeast, the suicide rates, and these are all numbers per 100,000, are quite similar to Europe. And in many states, they haven't changed at all over time. Okay, so they're low and flat. If you look at some of the states in the Midwest, like South Dakota, Wyoming, Montana, and Alaska, they have suicide rates that are 6 or 7 times higher. Okay, now is that because they have 6 or 7 times more people being diagnosed with depression? or saying that they're hopeless? No, it isn't, right? So it's not correlated with that. But one thing it is correlated with is places where you have a lot of gun ownership in the United States. Okay, so what this figure is showing is suicide rates by region of the US. So the purple line is total suicides, and then the other lines are all showing suicides by cause of death. So the green dots are suicides by suffocation. The blue dot dash line is suicides by firearms, and then the orange and blue lines are poisonings or drug overdoses and all other causes of death. Okay, so you can see that the really big ones are deaths by firearms and deaths by suffocation, and the really big difference between regions, like what's different about the Northeast than the other pictures, is the very low rate of firearm suicides in the Northeast compared to the other regions of the United States. Okay, so this suggests that something like gun laws may be very important. So to look into that a little bit, we used data on firearm laws that were nicely collected already, and we grouped them according to a lobby group called Every Town for Gun Safety's characterization of these laws. And then we estimated models at the state year level that were looking at the effects of changes in gun safety laws on changes in youth suicide, controlling for the number of people who said that they were hopeless. Okay, so what are these gun safety laws? You can group them into 5 broad groups. One is whether you have background checks or you need a permit to own a gun. Another one, extreme risk laws, are laws that say that you can take a gun away from somebody if they're a risk to themselves or others. Secure storage or child access prevention laws, that's sort of self-explanatory. There are laws requiring permits to carry a concealed weapon. And then there are laws which you could characterize as saying that somebody has a duty to try other means before they resort to firearms. Okay, so if we look at this, what we see is that an additional gun safety law is associated with about a 6% reduction in youth suicides. That's the first column. And then we can break that out. So what you can see in the other columns is that it affects suicides by firearms, but it doesn't have any effect on suicides by suffocation. So there's no substitution here. It's not like if you take people's guns away, they go and kill themselves in some other way. They don't. And so the difference between deaths by firearms and deaths by suffocation is also statistically significant. And then the next line down is showing that the percent hopeless matters too. So if people are hopeless, they're more likely to commit suicide, but that has an independent effect, or putting it the other way around, the gun laws have an independent effect. We also focused on 2 laws where there's been a lot of movement recently in the United States. One is the repeal of these concealed carry laws, so that makes it much easier for people to have hidden guns. And the second is passage of what people have called shoot first laws, or stand your ground laws, which are laws that basically take away this duty to try other means before resorting to firearms. So you could characterize these as maybe gun freedom laws as opposed to gun safety laws. And what we see when we look at those is in this diagram, the blue dots are showing the before period to the law change, and the red dots are showing the after period. And so you see that when you pass one of these gun freedom laws, you get increases in suicides due to firearms, but again, no change in suicides due to suffocation. Okay, so these firearm laws seem to be affecting suicides by firearms and not other types of suicides. Okay, so coming back to the social media question, do trends in the use of social media explain these geographic differences? There are some very nice studies showing that if you pay people not to use their phones, say for a month, that they report being in slightly better mental health. We also saw a very nice paper today at this conference that was looking at high-speed internet rollout in Spain and found that that had a significant negative effect on the mental health of girls, but it was very small. So it accounted for some, but very little of the reported change in mental health problems for girls. In the US, social media use is actually negatively correlated with suicide at the state level. So you can see these three outliers over here. These are the three states that I was telling you about, Alaska, Montana, and South Dakota. They have very high suicide rates, but they actually have low levels of social media use. And if I took those 3 points away, you'd get an even steeper downward sloping line. So the fraction of kids using screens for over 3 hours a day is actually negatively associated with suicide. Okay, so now I want to turn to the third part of my remarks and talk about some of the investments that have been shown to positively affect children's mental health. And I guess my argument is that this is more where we should be looking instead of talking about banning social media, taking people's phones away, and so on. So the importance of this is that if we don't provide evidence about the effectiveness of programs, then it's much easier to just cut the programs. Okay, so starting at the beginning with the prenatal period, there's evidence that investing in mothers during the prenatal period has a positive effect on child mental health. So this is an example of a study that I did with Anna Chorney looking at a program that provides nutritional assistance, but also medical care, puts people in touch with social programs. And so what we did was we looked at kids who were covered by this program prenatally, again, compared them to their own siblings who weren't covered by the same program. And what we found was that the children who participated prenatally in this program had lower probability of having ADHD at ages 6 to 11, and also a lower probability of having other mental health conditions that are commonly diagnosed in that age group. Okay, so prenatal support seemed to have a positive effect on outcomes. Moving up to the preschool period, there's a lot of literature looking at preschool education and how it affects children's social and intellectual skills. There's starting to be more evidence that it also improves their mental health. This study was done in Norway and started with the observation that parents who have mental health problems are more likely to have children who have mental health problems. So there's a strong intergenerational correlation. So what this program did was target young children of parents who had mental health problems for specific interventions. They did more screening. They coordinated with the child care centers to provide more support to those children. They put them in touch with specialists and so on. And the program had a very big effect for the young children who are eligible. So the program affected children up to 6 years old, and you can see that for the youngest children who were in this program, there was a big reduction in the extent to which mental health problems were transmitted from parents to children. There was a 40% reduction in that intergenerational correlation. So moving along to school-age children. With school-age children, there's a lot of evidence that we have a problem. Some of that evidence can be seen in patterns of suicide over the course of the year. So in the US, what you see is a dip in the suicide rate during the summer holiday and also at the December holiday, and then higher levels during the time when kids are in school, basically. The two lines here, the first one is showing children 12 to 18 who are likely to be in school, and then the dashed line is showing children who are 19 to 25, and you can see that you don't see the same seasonal pattern for them at all. So this is for the US. There's also a nice paper looking at the same thing in Germany, where across different states of Germany, you have very different timing of the school year. And this finds that school holidays cause a 16% decrease in the probability of suicide, and that suicides spike in the first 2 days that kids come back from the school holidays. Okay, so that's very sobering. More evidence that schools are not a happy place for at least some children is that youth suicides fell with the closures of schools in March 2020. And then in the United States, there was huge variability in when schools reopened. And you can use that variability to see what the effect of reopening was. And that increased suicides again. Now, one suggestion about what the problem is in schools may have to do with bullying. Bullying's been around for a long time. Cyberbullying is a relatively new phenomena. A lot of people were worried during the pandemic that there would be more cyberbullying because all the kids were online. But actually there was less cyberbullying because it turns out that in-person bullying and cyberbullying are complements. A lot of the cyberbullying that takes place has to do with things that happened in person at the school. And so when the schools were shut down, both types of bullying decreased. Another possibility for why schools are associated with mental health problems is just stress. So some kids are under a lot of pressure to perform, and that may be one of the things that leads to mental health problems. In a study of children in Taiwan, where there are very high academic expectations, we looked at children who were born before and after a very fixed school entry date. So basically, kids who were born in August could go to school 1 year earlier than kids who were born in September, who had to wait for a year. So we compared the August born and the September born and see when the August born hit milestones like entering middle school, what happens to their mental health. Okay, so what we see here is that there's a big jump up in the number of kids taking antidepressants when they enter middle school, which is apparently when the pressure really turns on in Taiwan. And then when the kids finish writing their high school entry exams at the end of middle school, the number taking antidepressants goes down. Okay, so these academic pressures may also be part of the problem. Now, there is evidence that providing mental health services in schools can be an effective way to address these problems. There's a very nice study by Ezra Goldberstein and co-authors looking at the rollout of a program to put licensed mental health counselors in schools in Minneapolis. And what they find using administrative data is that there was an increase in the use of mental health services when the services were available at the school, a reduction in suicide attempts, and that this was achieved without basically any change in academic outcomes. So they could shift resources to this purpose, improve mental health, and not cause any deterioration in academic outcomes. Okay. So there's other promising interventions, which I don't have a lot of time to talk about, but I'll just talk about briefly. One is that a lot of US states, well, all US states now have passed anti-bullying laws. Again, this happened at different times in different states, so you can see what the effect of that is. And what's been shown is that these anti-bullying laws, which usually obligate the school to take allegations of bullying seriously and do something about them, have reduced youth suicides. Health insurance is important, access to health care. There's a study by Eliza Yacoum showing that if you look at children who were being treated for mental health conditions and were on public health insurance, when they turn 18, they lose their public health insurance, and she finds that subsequently they're more likely to end up in the criminal justice system, which shows that the treatment was helping them. There's a program in Chicago to provide what's essentially cognitive behavioral therapy along with tutoring in schools that have a violence problem, and that's been shown to reduce violence and bullying in those schools and to have positive effects on mental health. I talked a little bit about the importance of firearm safety laws, and then what I want to spend my remaining time talking about is talking about improving mental health treatment. Now, one reason why this is an interesting thing to study is that there's so much variation in mental health treatment. And it's not just about whether you got to see somebody or not, it's also about the type of treatment that you get if you get to see somebody. So what this map is showing is 30-day antidepressant prescriptions per child, 10 to 19, by county for just 1 year. So the darkest red areas are places where there was almost one prescription per capita per year, and then the lightest yellow are places where hardly anybody got a prescription. So this is just a checkerboard. It doesn't seem to follow any pattern in terms of region. And you just see that depending on what county you're in, you get very different treatment. Now, this isn't only a US thing. Again, I tried to find some Spanish data on the same phenomena. This is from a paper using national data on ADHD medication prescriptions per capita. And so there's a 4 times difference here from Navarre, which has 414, down to Murcia, which has 127. So again, a big geographic range across areas in the way that people are being treated and whether they're being prescribed ADHD medications. Okay. Now, along with that variation, there's a lot of very concerning prescribing going on. This figure is from a study that I did with Emily Cuddy, looking at children who had health insurance, who were being treated for mental health, and they're being treated for the first time. So the average age in the sample is about 12 years old. So think somebody who's 12 years old who is showing signs of depression. They go to the doctor, and what happens? Well, in the United States, 15% of those kids would get benzodiazepines. 13% would get a drug that was not approved for any use in children by the Food and Drug Administration. 4% would get tricyclic antidepressants, which is not the right thing that you're supposed to do. You're supposed to try SSRIs. And then 13% of them were getting multiple prescriptions on their first visit to the doctor. Okay, so only 55% of the children were getting something that most guidelines would say was appropriate, which is an initial prescription of a SSRI. Now, we also tried to look at whether these prescriptions, which looked very questionable, were associated with future harm. And so we followed this sample of children who are being treated for the first time, and we say, okay, if you got treated with one of these concerning prescriptions, let's call it a red flag prescription, did you have a worse outcome over the next 2 years than if you were treated with something that was FDA approved? And what we see, and we can use things like the type of providers who are in the area, and practice style as measured by how much prescribing people in your area are doing of these different things as a way to predict what treatment you would get. And so what we find is if you get treated, you have slightly lower probability of self-harm in the next 2 years than if you didn't get treated. But the rate really depends a lot on how you got treated. Okay, so if you got treated with one of these red flag drugs, you have the highest probability of self-harm over the next 2 years. And if you got treated with a FDA-approved drug, you have the lowest probability of self-harm. Okay, so there's some evidence that it actually matters that these people are being treated in an inappropriate way. Okay, so I'm going to wrap up here and say I hope I've convinced you that the child mental health crisis is very costly in an economic sense as well as in a public health sense. Also, that this crisis has been around for decades. Third, that suicide rates really vary a lot, conditional on mental health, which is actually a hopeful thing because it suggests that even if you don't move the needle that much on mental health, you could still affect suicide rates. And then fourth, there are things that we can do that improve children's mental health, that have been shown to improve children's mental health, to reduce the toll of this mental health crisis. So I will stop there and I'd be happy to answer questions.
Thank you very much, Janet, for this very interesting talk. So we have time for questions from the audience. Please raise your hand and introduce yourself. Yes, please.
Hello, can you hear me, Miss Currie? Thank you. Hello, in English.
I really wanted to thank you for this conference. It was great to see a new part of mental health in young people. It was really illustrative and it shed some light on the reality of this topic. So my question was related to the difference that we were seeing in the graphics between the male and the female rate. I had some knowledge that there is a significant difference between female and male. I think that the female normally have a higher rate in suicide ideation, but the male normally attempt suicide more. So I wanted to ask you, why do you think there is such a significant difference, well, in all the years that we have seen between female and male rates and suicide?
Yes, thank you. Thank you very much for highlighting that. I didn't mention it going through the talk, but it's another thing that shows that measured rates of mental health are not always very predictive of suicide, right? Because males always have higher suicide rates, but females always have higher measured rates of mental health problems. Females also attempt suicide more, but they use much more non-lethal means. So women are much more likely to take drug overdoses, but then they're also likely to be saved. So you saw in the diagrams that that poisonings were a very small fraction of suicides. Yeah. So there's lots of different reasons why women may be more likely to be diagnosed with mental health conditions. There's some probably hormonal factors. So for example, we know that there's pregnancy-related depression is an important thing. But there's also, women are much more likely to seek care generally. And so if you seek care more, you're more likely to be diagnosed with things. So I think those are two important factors.
Hi, thank you for the lecture. There is this trend now to ban any mobile phone on schools, you know, aiming to reduce the mental health crisis. What's your opinion on this? Would you consider this a good measure?
So I think there's two separate issues. One is whether the mobile phones are interfering with schooling. And so I think it might be a good idea not to have phones in the classroom from an educational point of view, but I don't think it's going to have any effect on mental health.
Seth? Yeah.
Just want to echo the other, comments. Appreciating the talk, it was very good, enlightening. For somebody not in the field, really, poisons came up as a type of suicide. Drugs have been mentioned sort of in passing, and I'm wondering where the opioid crisis or opioid epidemic fits into this, and how do drug overdose deaths and maybe like drunk driving deaths or things like that. I'm assuming they don't always get coded as suicide in these data sets. So I'm just curious, I guess, A, what does that mean for the data? And B, like what do we know about the intersection of opioid epidemic and alcoholism and mental health?
Yeah, actually, Dave Marcotte would be a good person to speak to that issue. But I think the pattern of the opioid crisis doesn't match very well geographically with the suicide pattern. For example, Appalachia was a real hotspot for the opioid crisis, but doesn't seem to be a huge hotspot for youth suicides. I also think the issue with mismeasurement is possibly important, but it has not been until recently that the opioid epidemic has kind of reached high school age kids. It was more for people who are a bit older.
I will try to make this question in English, if not in Spanish. My question is very simple. What will be in the future, so 2050, this youth who comes to adult, what will be the trends? The youth who has been treated well, youth who has not treated well, youth who has not appeared to doctor because pressure of family or himself. How is the trend in the when these youth people comes adult?
I think your question really highlights the importance of good treatment because it does make a difference in how people do. And so the people who are being treated early should have better outcomes than the people who are not. So I think a lot depends on making treatment available, but also thinking about the quality of treatment. So far most of the public discussion has been in terms of, oh, there's a shortage of mental health professionals, we need more child psychiatrists and so on. That may be true, but even with the providers that we have, we could be doing a better job, providing better guidelines, trying to maybe correct people who are prescribing a lot of inappropriate things, letting people know what they should expect in terms of mental health treatment. I think educating consumers as well could be useful.
John?
Yeah, thanks very much for a fantastic presentation and overview. I'm just curious about the next oldest age group, so students in colleges and universities, and I'm curious whether you've done any research on change in prevalence of students needing mental health accommodations, whether there's socioeconomic disparities that arise because lower income students are less able to get the medical documentation to get extended test time, and just in general, whether you have thoughts on like the optimal response of colleges and universities to the mental health crisis.
Right. I think, so one thing I also should have said in response to the last question, in a way, it's a good thing that everybody's talking about the mental health crisis, right? Because maybe this time we'll actually take some actions that will help. For college professors, we all see lots of kids with mental health problems in college, and it seems to us that there's been a huge increase. And some of that is actually a success story in the sense that kids who wouldn't have made it through high school because of their mental health problems, now they made it to high school and now they're in college and now they're our problem, right? Because they've made it that far. So I think some of what we're seeing in the colleges is a reflection of better treatment for youth, or at least more awareness for youth, more people who come in with accommodations and so on. Yeah, I don't think people have looked very carefully at whether the programs that are being offered in colleges are actually very effective. A lot of colleges offer very short-term counseling and then kind of refer you out to the community, but they don't do much quality control, so they just give you a list of every single provider in the community, no idea which ones are good, which ones are not. So I think colleges probably could do a lot better job of supporting their students that have mental health problems.
I have a question. So it seems to me that it's really critical to provide treatment or interventions to people who really need it, and equally important is that we do not provide treatment to those who do not need it. But that's really a very challenging task, and it seems like things are getting more complicated as we change the guidelines. It seems to me that, programs that are offered to all students are not necessarily the best, because not all students need to be exposed or need treatment. So that's, to me, is like a big challenge. What do you think of the role of AI techniques in identifying people who may need treatments? Do you think AI plays a role or will play a role in the future?
That's a very interesting question for many reasons. One thing I will say is that, at any given point in time, say 13% of kids have a mental health problem. Something like 13% of adults have a mental health problem. People get better, then they get worse. And this is a very common thing. It's sort of part of the human condition to have mental health problems. So I would argue that providing education to people about mental health is probably a good thing, given Like the probability that you or somebody in your family or somebody that you're close to is going to have a mental health problem is basically 1. So, so more education and discussion about it is good. Thinking about AI, this was actually way back in the 50s, I guess, Danny Kahneman was interested in using AI in psychology. That was one of the first examples that they used. And he argued that AI could do better than most psychiatrists, that psychiatry was particularly bad in terms of diagnosis, and that AI would be better. I don't know that anybody's really taken him up on that, but what I think would be useful, and which you don't hear much discussion about, is that people think about AI as sort of substitute for doctor, or telling the doctor what to do. So you feed in a bunch of data and it says like, oh, you should give this drug or something. I think it might be more useful to think about it as, well, let the doctor do their job, like make a decision about what should be done within some bounds, and use the AI to set bounds, right? It's like, have an AI thing that comes up and says, this person is 12 years old, has never been treated for anything. It's clearly inappropriate to give them barbiturates. I think that would be a good thing. So using it more to get rid of the really bad prescribing than to be really prescriptive about what a particular doctor was supposed to do.
I think we have time for one more question. Dave?
Thanks. It was a great talk. I wonder if you have any thoughts about the differences between suicide trends for young people in the United States and many European countries. And we've talked about the relatively low rates of suicide. You highlight the importance of firearms in the United States as a primary driver. You focused importantly on inappropriate treatment in the United States. Are Europeans treating depression and identifying or screening depression among teens better than we are in America?
So I think it probably depends a lot on which country that you're talking about, and so I can't speak for all countries. I know in some countries there's probably much less of this really bad prescribing than there is in the US. So in the US, doctors can prescribe whatever they want. And people are always surprised when I tell them that there really isn't any kind of binding guidelines. The other contrast would be a place like Denmark, where to get mental health treatment through the public system, you have to go to a hospital, you have to see a child psychiatrist, you would get somebody who's very expert treating you, and you would be treated according to a protocol. Right? So it really varies, and that could have something to do with, say, availability of treatment, and also not having bad treatment might have something to do with rates, in addition to things like availability of firearms, which is something like 42% of US households have a gun, right? So if there's a gun there and you feel suicidal, then it's much more likely to be fatal than if not.
I think we are right on time, and thank you, Janet, again for this very interesting and enlightening talk. And let's join me in thanking Janet for her wonderful speech.